Hello, this is a film to be presented at the Gastroenterology Film Festival at BSG 2017. Our film is called TOP Tips, or Transjugular, Intrahepatic, Portosystemic, Shunt. In this short video, we would like to cover what is a TIPS, how does a TIPS work, the evidence-based indications along with contraindications, potential complications to be aware of, a brief overview of the procedure itself, and lastly, where to find out more and further topics to supplement this learning. TIPS is an artificial connection between the portal and systemic venous systems within the liver. The aim of this is to reduce the pressure within the portal system, which is elevated by the impedance of blood flow through the liver in liver cirrhosis. Direct measurement of portal pressure is clinically impractical, but we can measure something known as the hepatic venous pressure gradient. A catheter which measures pressure is introduced into the hepatic vein via the internal jugular vein and then the inferior vena cava. A measurement taken here represents the free hepatic venous pressure, for example, 15 mm of mercury. If blood flow through the hepatic vein is stopped or wedged by a balloon, the static column of fluid in a cirrhosed liver transmits the pressure from the portal vein, for example, 20 mm of mercury. The hepatic venous pressure gradient is the wedged hepatic vein pressure minus the free hepatic vein pressure. So if the wedged pressure is 20 and the free pressure is 15, this would leave the hepatic venous pressure gradient as 5. The normal range is 1 to 5. A pressure gradient greater than 10 is considered to be clinically significant portal hypertension. A hepatic venous pressure gradient greater than 12 crosses the threshold for variceal rupture. The procedure of a TIPS is performed in the interventional radiology suite under fluoroscopic guidance. The idea is a side-to-side portocaval shunt that connects the portal and hepatic veins within the hepatic parenchyma. Firstly, vascular access is created by the puncture of the internal jugular vein, which is done under ultrasound guidance. One of the hepatic veins is then catheterized, and the liver parenchyma is punctured to create a tract through to one of the main branches of the portal vein. The portosystemic pressure gradient, or PPG, is then measured. The parenchymal tract is then dilated by a balloon, and the stent is then deployed. The portosystemic pressure gradient is then reassessed, and the tract may be dilated further to ensure the desired target pressure is reached. The initial aim of a TIPS was to bring pressures below 12 mm of mercury, but now the optimal reduction is under interrogation by empirical research and will likely vary based on the indication. For example, a different target for variceal bleeding compared with refractory ascites. An important point is that a TIPS does not alter the portal vein anatomy, which is an advantage if the patient subsequently undergoes liver transplantation. With regards to indications for a TIPS, in the emergency setting, this would be an initial treatment failure in severe acute variceal bleeding, or in other words, a TIPS should be considered in a patient with bleeding ongoing after endoscopic therapy. Prognostic scores have been shown to be helpful in decision-making in order to accelerate a TIPS referral in high-risk subjects. A TIPS should be placed within 72 hours, but ideally within 24. Non-emergent indications include secondary prophylaxis for variceal bleeding. Randomized controlled trials evaluating the use of TIPS in first variceal bleed prophylaxis are awaited. In ascites refractory to diuretic therapy, TIPS has been shown to reduce the incidence of tense ascites and paracentesis and increase transplant-free survival compared with when large volume paracentesis is used as the mainstay of treatment. TIPS can improve renal function in patients with type 2 hepatorenal syndrome who are awaiting orthotopic liver transplantation. More recently, TIPS has been used in Budd-Chiari syndrome and veno-occlusive disease, although patients who have had chronic courses of disease may experience more benefit. In Budd-Chiari syndrome, in which of course the hepatic vein is occluded, a direct approach to the portal vein from the inferior vena cava can be considered. TIPS can be used in refractory hepatic hydrothorax to reduce hydrothorax and frequency of thoracocentesis. Contraindications to TIPS include recurrent or persistent overt hepatic encephalopathy, grade 2 or above on the West Haven scale, despite adequate treatment, subclinical hepatic encephalopathy, which is detected on EEG, severe liver failure, severe organic renal failure, heart failure, severe portopulmonary hypertension, i.e. a mean pulmonary arterial pressure greater than 45 mm of mercury, or uncontrolled sepsis. In terms of complications, there is hepatic encephalopathy, of which overt episodic or recurrent encephalopathy occurs in up to 67%, and persistent occurs in approximately 8% of patients who are followed up over 2 years. However, pharmacological prophylaxis is not currently routinely recommended. In addition to encephalopathy, the other big Achilles heel of this procedure is stenosis or occlusion of the stent, with around 75% becoming occluded over 6 to 12 months in some studies. The stenosis is due to a process of pseudo-intimal hyperplasia. A TIPS venogram, ideally with a measurement of pressures, is the gold standard for making the diagnosis of stenosis and should be performed in the event of recurrent varices. In a recent meta-analysis, covered stents were shown to have a significantly higher probability of survival and shunt patency and may open up new indications or lower thresholds for TIPS. Thrombosis of the stent is possible and carries a theoretical risk of pulmonary embolism. Hemolysis occurs in 10% of cases and is an important complication to recognise as, of course, the consequent jaundice can incorrectly be interpreted as worsening of liver disease. Post-procedure mortality is generally accepted to be low. 30-day mortality varies between studies but is likely significant. Infections of the stent are possible and should be suspected in a clinical syndrome of fevers, tender hepatomegaly, positive blood cultures, and a demonstrated thrombus or vegetation on the stent. Punctures, for example of the liver capsule, and fistulae are possible. In the event of jaundice and sepsis, consider a fistula between the tips and the biliary tree. In terms of further learning, it might be useful to review the TIPS pre-assessment, including echocardiography, the risk factors for post-TIPS hepatic encephalopathy, and the Mayo risk score for TIPS mortality. Thank you to everyone who has made this video possible.